if you if you do want to go off and watch a bit of TV or something like that, perfectly reasonable. Maybe you do go off and come back. I don't know. Anyway, nice to see you all. Yeah, we're just going to assume it's all okay on Facebook. I have got this new microphone system, but I'm not gonna let it get in the way. So I'm going to put it there. It's not in the way, is it? This big thing still in shot. Still in my shot. There you go. Right. So I'm kicking straight off because I've reflected on these Q&As and I've looked back on them because I put them on this podcast. You know that as a podcast. I don't really advertise that, but I don't know how interesting the podcast will be because it's just the audio of these. Anyway, point is, I do find that there's quite a lot at the beginning before I start talking about anything relevant. So I'm going to start talking about something relevant right now. And that relevant thing is this question. Joe is here and saying hi. Hi, Joe. Nice to see you. Someone is on Facebook. That's what we want. Right. So if you've got a question, feel free to post away, by the way. I am very open to questions on the hoof. But in the absence of any questions, I will talk about what I've got here. And what I've got here is a question that says something like this. Does abdominoplasty include lifting / removing excess fat / skin of the mons pubis, or is this an additional procedure? It does a bit, but if you've got an awful lot of excess skin / fat of your mons pubis area, it may be an additional procedure. So it's something we'd have to talk about pre-op, and it's a good thing to point out pre-op because a lot of people don't realize they've got excess fullness on the mons pubic area because the abdominal apron is in the way. And it's probably mainly talking about people who've had significant weight loss, like several stone in weight being lost. And so if you have had significant weight loss, then your probably overriding concern is your abdominal apron. But it's important for us as surgeons to have a look at the mons area to see if there is excess skin and fat there, because what sometimes happens is you get rid of that abdominal apron and the patient see this bulging mons. The mons, by the way, is the area basically where your pubic hair is. And they say, what have you done? What's all that? And you're like, well, it was, I haven't done anything to that because it was already there. So it's important to be aware, if there is an issue there of that preoperatively, and also important to be aware of what we can do. So we can do stuff to that mons area. We can do some liposuction to take some of the fat out of it, to take some of the heaviness out of it. And there is a limited amount of skin resection you can do of the mons. You wouldn't do a significant amount of skin resection to the mons area at the time of a tummy tuck, because any resection would be going south and that would make the scar pull up north. I don't know if it would make the scar drift up. So you don't really want to undermine too much south. All you're undermining when you do a tummy tuck is north, because you want to free up the skin on the north part so that it's mobile and it comes down to the south part. So your scar ends up in the south, in the bottom scar of a tummy tuck, in the bottom ellipse. Yeah, tummy tuck's an ellipse, and the scar ends up in your underwear. So you undermine north and nothing south. And doing stuff to the mons would involve undermining south. I'm sure there's some kind of model I could, I'm trying to think of some analogy or model, but I don't know if that's clear to you. You have to be there, to see that top skin's very mobile and comes down, and you want the bottom skin not to be mobile, because if the bottom skin's mobile, it will drift up and the scar will meet halfway. So if you take an ellipse out of a tummy tuck and the scar meets halfway, then you've got a scar across the, your abdomen, which doesn't look good. So yeah, so answer is you can do some removal of excess skin and fat of the mons area, but if it's significant, you might need another operation, so-called monsplasty, once everything's healed, where you can then take away that ptotic skin and fat from the mons. Droopy. Ptotic's another word for droopy, by the way. Ada says, sweet evening. Sweet evening, Ada. And nice emoji. Thank you for that. My belly button is scared. would it still be used for an abdominoplasty or a new one formed? I think it's scarred, actually. Well, it depends on how badly scarred the belly button is, but the bottom line is, we could make a new one. It is possible to make a new one if there is a problem with your belly button. But the bit of belly button that we use when we do a tummy tuck is just the bit inside, the bit that goes in down into your abdominal wall. We don't use any bit that's on the surface of the skin. So it would depend where the scarring would be. I'm assuming the scarring would come from a piercing. Is that a fair assumption? I don't know if that is where the scarring is from, or if you've got scarring deep down inside your belly button. If you have got scarring deep down inside your belly button, then there would be a bit of a concern that maybe you wouldn't be able to, the blood supply of that belly button might be compromised. So you might not be able to keep that belly button anyway. So there was significant scarring around your belly button. But difficult to answer that question on here, to be honest with you, because probably need to see it. No photo, unfortunately. Do like a photo. If you've got any photos that you don't mind sharing, if you scarred belly button, then I would be very happy to. There's lots of hearts coming on Instagram. Not quite sure what that signifies, but it can't be a bad thing. So if you've got a scarred belly button, have no fear. You could have a new one made at the time of a tummy tuck, and you might have to have a new one made at the time of a tummy tuck. But if it's just scarring in the skin around the area, you wouldn't need a new one. You could keep the original one. Will breast implants reduce the space between breasts / cleavage, or will it exaggerate it? So this is a good question, and I think a lot of people are concerned about that, rightly so, because good, look, we got a question on Instagram. Thank God for that. It's a bit worried I wasn't getting any questions then. I was going to have to drag these out. How many have I got? I've got 3 more. Okay, well. Sahel, I will come to your question in a sec. Will breast implants reduce the space between breasts, cleavage, or will it exaggerate it? Well, this is something that people worry about, quite rightly so, because obviously the most cosmetically sensitive area when you're doing a breast implants is the cleavage area, and so people are really worried about the cleavage area. And what I normally say is the distance, all being well, the distance between your cleavage will be the same, but it will be enhanced. So the angle will be increased. So some people have a bit of a gap between their breasts naturally, and that gap will remain. But if you haven't got much breast tissue, that might be flat, and it will be enhanced when you have breast implants. If you haven't got much of a gap and your breasts are quite close together, then again your breasts will stay close together, and that gap will be that shape will be enhanced in the cleavage area. So it's difficult to know where this patient's going, whether they want it enlarged or not. So if some people want the cleavage to be closer together, sometimes people say, I don't like the gap here, particularly if you're very slim. You've got to be a bit careful, because you don't really want to put the implants too far medial to where the breast tissue is. So if the breast tissue's here, Instagram I think seeing this, but I think my question's over the top of Facebook, so let's get the question out. So if you oh sorry, that's the next question. If your breast is here, you don't want to put the implant too far that way of it, because you'll be able to feel the implant. So you really want to keep the implant hidden by the breast. So you want to keep the breast within the footprint of you want to keep the implant within the footprint of the breast. So you don't want to. It's difficult to close down a wide cleavage, because if you're doing that with implant, the worry is you'll be able to see or feel the edges of the implant, see some rippling, feel the edges. That's the concern. Sometimes people have got an abnormally wide cleavage. Usually it can be something associated with a tuberous breast deformity. And so those are always challenging cases. So you might have to do something that try and narrow down that space. But as a rule, the space tends to be about the same as what it was preoperatively. One thing people worry about when they're having implants is having it abnormally wide, as in wider than what they have. And this is not what we would hope would happen, but it is a risk, particularly when the implants are placed under the muscle. Because when the implants are placed under the muscle, the muscle can push the implants laterally, and you can get an abnormally wide cleavage. I've done a blog post about that. Google Staiano wide cleavage. God, that's conjuring up some images, but I did do a blog post on wide cleavage, and it is usually when the muscles are pushing the implants laterally, because when you do the surgery, when you put them under muscle, there's lots of quite big blood vessels, perforating blood vessels in that area, and sometimes we get a bit worried if there's a bit of bleeding and we don't dissect well enough medially to release enough of the muscle. And if we don't dissect the muscle enough and you leave too much of the muscle there, it can push the implants wide. So we need to really make sure and focus on that cleavage area and make sure the space is made properly in that cleavage area, so that we don't get a wide cleavage. So the aim usually with the breast implants is to use the same cleavage that you've got, the same absolute distance between your breasts, but enhance it, so to make the angle higher. I hope that's answered the question. I'm not sure what angle you're coming from. Is whether they're going to be too large, they're too wide or too narrow. The best thing is to look at you and say, look, this is the distance. You've got a bit of a gap there. I'll leave that gap because that's usually bone. That's usually sternum. You don't really want to put implant there because you'll be able to feel it because it'll be right on top of the bone. So we've got some questions on Instagram. Thank the Lord. Hallelujah. Facebook, have a word with yourselves. Get some questions in. Sahel, hello, Mr. Staiano. What's the scars like for breast reduction? That's a good question. So the scars can vary for breast reduction, and part of a breast reduction is a breast lift. That's the first thing to say, because a lot of people will say, I need a lift and a reduction. And you've got to be a bit careful, because if you speak to someone who doesn't really, not really sure in the billing and in the sort of finance office of the hospitals, and you ask for a quote for breast lift and reduction, you could, we've done this when we've spoken to them. If you ask for a quote for a tummy tuck and a breast lift, they'll take the price for breast, they take the price for one of them and then make a discount on the second one. There's always a discount for doing multiple procedures because there's economy of doing multiple procedures, but they'll basically add them together and say, it's thousands of pounds. So if you ask for a breast reduction with a breast lift, what you don't want them to do is take the price for a breast reduction and then take a price for a breast lift and add them together, because then that'll be doubling the price, which will be ridiculous. So basically, a breast lift is an integral part of a breast reduction. You don't have to ask for it. It's part of it. And the lift aspect is tightening that skin and moving the nipple to a higher position, because the nipple's usually at a low position. And in order to move the nipple to a high position, you have to make a scar around the nipple. So the scarring of a breast reduction can vary, but there's always a scar around the nipple because the nipple's always moved. So the minimum scarring you can have is just a scar around the nipple. I guess the minimum scarring would be a crescent lift. Someone was asking me about this the other day. In the clinic, they wanted a crescent lift, which is just basically a half moon. So you just make a scar the top half of the nipple. I think that might move the nipple a little bit. It runs a risk of elongating the nipple and is certainly not going to do a breast lift. So I would say the minimum scarring, certainly for breast reduction, would be a circumareola all the way around the nipple, and that's the minimum. A lot of people say, I want minimum scarring, please. I want to give you minimum scarring. Every surgeon wants to give you minimum scarring. If we give you no scarring, goodness knows we would. The problem with minimum scarring is the minimum scarring means less skin's taken out, less of a lift is performed, and so therefore perhaps less of a result that you're going to get. And personally, I don't particularly like the results that you get with a circumareola, so-called Benelli lift or reduction. You can do a reduction through a circumareolar incision, and I think you're going to get a better result if you have more scarring, because more skin can be taken out, and you'll get a better result. When you do the circumareola, you cut out a big donut of skin and you cinch in a big circle to a small circle, so the scar's often puckered, the breast can lack projection, can sort of flatten off the breast, and it doesn't give a great shape. So I don't particularly like it myself, but I think some people do, and so that might be an option. So circumareola is the sort of minimum, and then you've got your circumvertical, which will be around the nipple and then down, straight down, so-called lollipop scar. So that takes the skin around the nipple, but also you can take some skin out in a side-to-side direction and narrow the breast. Often when you do a breast reduction, the breast is too wide. So that will narrow the breast and give more projection, give it more of a pyramid sort of shape, and give more projection to the breast because you're tightening that skin at the lower pole. That's your lollipop circumvertical. And then finally, you've got your inverted T or anchor scar, so around the nipple, straight down, and then one in the fold. And you can have a short T or a full anchor. I've got to be honest, I like the anchor. I try and keep the horizontal scar as short as possible. In terms of the scarring, the most obvious is the one around the nipple, and then the vertical. The horizontal one is often pretty well hidden and is not obvious, and the horizontal scar will allow you to take out skin in an up-down direction as well as the side-to-side. Like the vertical scar makes you narrow the breast, and the horizontal scar means you can take skin in an up-down direction. If you don't do the horizontal scar in the fold, you can end up with too much skin because you in an up-down direction, and you can end up with ridges and folds, which sometimes need to be revised at a later date, which would be revising into a horizontal scar. And sometimes you can get a dog ear at the bottom of the vertical scar. And so I often just sort of take out that dog ear and take out a bit of up-down skin by making a short T if I can. If there's a lot of skin, then it will be a longer T, depending on how much skin there is. So round the nipple minimum, round the nipple and down is the next one, the lollipop or circumvertical, and then round the nipple down, and in the fold is your anchor or inverted T-shaped scar. So those are the options for breast reduction. More scarring, more of a lift, and more skin's removed, but more scarring. So, what we got here? Louise on Facebook's asked a question, but I think Connie was in for Louise. I don't want any fights. But Connie, I think. What's going on? Oh God, stuff's going on Instagram. Instagram's going. Connie, then how long can I expect to wait for a surgery date roughly? I understand it depends, especially now due to COVID. Yeah, Connie, I meant to tweet this. It's so hard to know what to tweet, isn't it? Do you find that? I find it really hard to know what to tweet. And I had a good tweet today. I've been to Spire for the first time in over a year today, and I thought, in my head, I had a picture of the Spire sign or something like that. Oh God! As I walked in, I thought of doing it, and then I thought I'd do it on the way out, and then now look at me, I'm here and I haven't taken a photo. I might tweet it anyway, but anyway, that was just a revision, so it wasn't a sort of full list, but anyway, so I haven't been to Spire or Parkway or Priory for a year, just over a year now. But hopefully things are going to start moving, and hopefully things are going to be starting to be done in the NHS more, which will release the pressure on the private hospitals. That's certainly what they're saying at the private hospitals. They're saying that they're going to be doing more private work. We are doing surgery. We have got dates in hospitals at the moment, but they're fairly sporadic, and it would probably be, people ask me all the time, how I'd say a few months. What are we now? March, April, May, maybe June, maybe? I'm not sure. If you ring the office or email us or something, we'd be able to give you an idea. But I'm going to say something like June would be our next date, I think. For major surgery, obviously, we've got a local anaesthetic theatre in the clinic, so we can do minor procedures sooner than that. But it's a few months waiting list just because we're struggling to get lists at the moment, Connie. I'm not sure if I think enhanced mastopexy was also. I'm going to do that. Enhanced mastopexy. I've had a breast reduction / uplift. Unfortunately, my boobs have no shape or volume now. I don't want implants. Could fat transfer to the breast help? Very good question. Enhanced mastopexy. It could help. And it is tough because you've got no shape or volume. So you want shape and volume. Yes, fat transfer will add volume and can, avoid the need for breast implants, no question about it. And I am not, I use a lot of implants. I mainly do breasts, and so I do use a lot of implants. So I don't want to be negative about implants. But if someone can avoid having implants, I would say avoid having implants, because I totally understand that people don't want to have implants. There's all sorts of risks and complications and things like that you can have implants. They're very rare, but still they're there. So I totally understand why people don't want to have implants. I don't blame you at all for not wanting to have implants. But in order to add certainly volume to the breast in a predictable way, in my hands, implants is still the gold standard. Fat grafting is great, and I love fat grafting, but it is limited as to how much volume you can put in fat grafting. So it's limiting how much volume you get there. So I'm looking personally, 50 to 100 mils per breast would be sort of where I'm at on fat grafting. You never use an implant that small. Your implant's going to be like 200 cc's, 300, 400 cc's. So for that reason, fat grafting is quite subtle, and it's also quite quite expensive, and you might also need to repeat it because it's only small volumes. The other thing in terms of shape, so certainly volume, it will give you some volume. You say you've had a breast reduction uplift. I always am clear to patients as what you can expect to achieve in terms of shape when you have a breast reduction stroke uplift. And we go through a lot of photographs, and I explain that actually, whilst it is quite full to start with, it does settle because it's your natural breast tissue and it's acted on by gravity. And you do get a concavity in the upper pole. When the nipple up, it's a concave shape. Some people say, hold on a minute, just had a breast lift. I want to have, And what they're thinking of is more the sort of shape you get with implants. With implants, you get more fullness in the upper pole of the breast. If you're not using implants and you're using your own tissue, whether that be with breast lift reduction or adding fat graft, you can add fat graft in. Fat graft is natural tissue as well, which is the benefit of it. But also the fact is it's acted on by gravity. It doesn't tend to stay in the upper pole. If you want sustained fullness in the upper pole of your breast, if you want a fuller look sort of from the nipple up, I would say implants are the only way to do it. I'm not saying you should have implants, but I'm just saying I don't know any other way of doing it. So if you don't want implants, I would just accept, well, I haven't seen what your shape is, but it's hard to get that fullness up there without implants. And I think fat grafting in my hands would just give you a bit more volume. So it would give you a bit more volume, but not a huge amount of volume. But it sounds like, you don't want more volume because you've had a breast reduction. So presumably, you don't want volume, you want shape. So it's a tricky one. So it comes down to being aware of what can be achieved pre-op, and that's something I talk about a lot, about how you get a happy patient. You have to be clear pre-op, and I try and be clear to everyone having breast lifts and reductions what sort of shape can be achieved, so I don't get this sort of thing, them saying afterwards, oh, I'm, wanted them fuller, what's happened, the shape's not right. I'm like, well, that's because it's your own tissue and it settles. I mean, it's probably better than pre-op, but sometimes people are not happy because they thought it would stay fuller, and whilst it does to start with, it always settles. That's why you've got to look at photos before and afters of people out of a bra for a start off. Don't, in a bra you can push them up and stuff, and sometime after surgery, once they've had a chance to settle, because when you first get done they're up there, but then they settle. Right, what we got, my private journeys here. We've got some waving going on. Louise, I haven't forgotten you, girl. I have not forgotten you. Why do some surgeons go by BMI and some do not? Thanks. Louise, I'm assuming you're talking about body mass index rather than the BMI healthcare company. BMI is their own Priory and Droitwich around here. So we're going to go on body mass index. And, if it's not, then stop me and say, no, I'm talking about the BMI hospital. So body mass index. Yeah, body mass index. Okay. Okay, couple of things. First of all, when you're in the NHS, when you're in or maybe when you're sort of in a company or something, you sometimes have guidelines or what's something that's stricter than guidelines. You have things you have to work within, and often BMI is there with that. So certainly in the NHS, when I was there, stuff like breast reduction, things like that, you have to have a BMI of 25, less than 25. So that was quite prescriptive. That was like, GP refers someone for a, breast reduction or something, you write back and say, confirm the BMI is less than 25 or I won't see them. So they're very sort of, regulations, exactly. They're very prescriptive about it. And they say, right, it's got to be that. So if you work, it may be that, I'm not sure about the companies, but certainly for the NHS, it was like that. So that might be why, if someone's been strict about it. But I think most surgeons are aware of BMI, and I think most surgeons will go by BMI and will be, will document the BMI. We want to know what the BMI is because it is an important marker. The problem is, Louise, when you get into this sort of thing, like anything, nothing's straightforward. Broadly speaking, the higher BMI, there's two things with BMI. So broadly speaking, the higher the BMI, the more your risk of complications. And there has been studies to show it. Again, when you look into it, there have been studies that to show that it's actually not that important. So there have been studies where people have done stuff on people with high BMIs, where they've done, say, tummy tucks, your classic, on people with BMI above 30, BMI below 30, and they've shown some where there's no difference. So it's not written in stone, but there are also some studies which have suggested the complication rate is higher at a higher BMI, and 30 is usually the cutoff. That means people do take for the studies. Nothing magical happens at 30. It's just what they take for the studies. So, often you'll be said, if someone says to me, what BMI do I have to be? I give them the spiel, but if you want a number, I say 30, because that's where the studies have stopped it. But there's nothing magic about 30. So broadly speaking, your BMI less than 30 is, I think, accepted to be where you want to be. But the most important thing, or maybe not the most important thing, but an important thing is you have to be happy and stable with your weight. Yeah, if you were losing weight, even if your BMI is less than 30, I would say to you, carry on losing weight, because who cares? It doesn't matter what it's 30. If you want to have a BMI of 28, get to 28 before having surgery, because if you lose weight after surgery, especially any of this body contouring stuff, tummy tucks, breast lifts, we're tightening the skin as much as we can. And the reason you need it is because the skin's been stretched, because your weight's been higher. So if you then lose weight afterwards, that stretched skin, you might have some redundant skin. So you're going to get a better result if you lose weight first. Similarly, if you're happy and stable with your weight and your BMI is above 30, particularly if you've lost weight. I mean, there's a lot of people out there who've lost a lot of weight. BMI has been 40, and they get it down to 32. What are you going to do? You're going to tell you, look, you've got to get down to 30, and I'm not going to do it. So, particularly people who lost a significant amount of weight, they're happy where they are. They don't want to lose any more weight. It'd be false in a way of them to lose the weight. They don't feel comfortable losing the weight. They're happy where they are. I think there is an argument to say that it's okay to do it above 30 personally. And I have done surgery on people who've had BMIs above 30. And, you do get complications on people who have BMIs below 30. And you can operate on people who have BMI above 30 and have no problems at all. So it's not a written in stone thing. But broadly speaking, it is better to be at a lower weight. But if you're happy and stable with your weight, I would say that's the most important thing. Sometimes it's easier for people to have these things to say you've got to have it lower than 30 and stuff, but so I think that's why maybe some surgeons do, because they're sort of within an environment where they have to. Could the scarring eventually fade if you had more scarring? Yeah, the scarring always fades, Connie, and especially the scarring for breast reduction I think you're talking about is hidden in the fold. The horizontal scar is hidden in the fold. The one around the nipple is probably the most obvious one, but it does all fade. And with the one around the nipple, bit of a amateur mistake there. I should have said areola. Nipple's a bit in the middle, but anyway, the one around the areola does fade, and because it's a pink, the areola is usually pink, and the skin is, a lighter shade next to it. Then often it sort of swallows up the scar a bit. My breasts are better, but they're just a bit flat. Thank you for answering my question. Thank you for asking the question, Enhance. And that's it may be. I don't know, but it may be that's often I see people who are unhappy, and I'm like, that's actually an okay result. It's not a bad result, but I think it's that they in their head thought there was going to be something different, and they thought they were going to be up there, sort of thing, and then they have it done, and they're like, not sure. So I think a lot of it is about expectation for patients, and I think that's where a lot of unhappiness comes in with this sort of surgery, that people are expecting something, and then when they get it, they're not happy. But the surgeons will all look at it and think, yeah, that's what it always looks like, what do you expect, sort of thing. So I think it is important to try and be realistic with patients. I show photos, try not to show my best photos, try and show, good photos, not bad ones, but not the best, because I want you to see results that can be achieved. And sometimes people say, well, that's not very good, that scar's a bit red, or that's a bit droopy. And I'm like, yeah, maybe when I was younger, I would have tried to sort of gloss over it. Yeah, but that's just an early result. It'll be better later on, or something like that. But now I'm like, yeah, well, that's what it is. If that's not a very good, then don't have it. because it is about expectation of patients. So you don't want to bolster up their expectations and say, no, that's her. You're going to get a great result. She's a bit droopy and she's got a different body to you and stuff like that. Realistic expectations. You don't want to put people off, but you certainly don't want to be unrealistic. That's where I am on the expectations question. Not that there was an expectations question, but I'm going to bring it in, right? That's a chairman's prerogative, right? Yeah. Yes, regulations. Louise getting the comments in. The comments are starting to roll now in Facebook. Right. Got a question from Sarah Townshend. Townshend? I think you spelled your name wrong, Sarah, haven't you? Anyway. Hi, I've recently been diagnosed with rheumatoid arthritis. Not been on any treatment as yet, but methotrexate has been mentioned. Will this stop me from having a tummy tuck with muscle and hernia repair? No, Sarah Townshend. No, it won't. Well, I better check with your surgeon first. But if the surgeon doesn't mean no. I mean, methotrexate is an immunosuppressant. So rheumatoid arthritis is an autoimmune disease, which means your own body makes antibodies to your own body and sort of attacks it. So the treatment is often to dampen down that immune response, which will help with the arthritis, but it will also delay wound healing. So methotrexate and immunosuppressants will delay wound healing and will increase your risk of infection. So there's no doubt that if you're on steroids is the other thing. If you're on these sort of immunosuppressant medications, then you are going to increase your risk of wound healing problems and infection. And a tummy tuck is a big op. So I think you'd have to take it into the mix. It's what we would call a relative contraindication rather than an absolute contraindication. So obviously, an absolute contraindication is where we say no, I'm not doing it because of something. So I don't think we'd say no, we're not doing it because you're on methotrexate. I think we'd have a discussion with your rheumatologist because you're not even on methotrexate at the moment. So you want to get your condition maximized and get you in the best place you can be, and then it could be okay, but to go ahead. But certainly if you were on methotrexate, or methotrexate was started in sort of perioperative period, soon after surgery, you would have to be accept that you're going to have a higher risk of complications, basically. And sometimes we do operate on people who have comorbidities, which will increase their risk of getting complications. And if there's nothing we can do about those comorbidities, like diabetes is a classic, if there's nothing we can do about those comorbidities, I mean, if there's something we can do about them, fine. If the diabetologist says actually they're a bit labile with their medication, we haven't quite got the right dose of insulin, we've got to get it sorted, and we just got to a bit all over the place with their sugars, we were like, okay, well, let's not do surgery yet, let's postpone it until we got that stable. Once it's stable and optimized with your medical conditions, then we make a judgment and we say, look, you're stable and optimized, nothing's going to change. We've got to make a judgment. You might have a higher risk certainly for things like diabetes, and if you're on immunosuppressants, you can have a higher risk of complications. What do you think? You'd be like, don't fancy that. I'm like, okay, fine. Or, I hate my stomach or whatever, and I'm going to take that risk. And you're like, okay, well, that's fine then too. So a bit like the BMI thing as well, higher risk with a higher BMI. Just have to balance it and just say to people, be open with them. Look, you're going to have a higher risk. If you can lose weight, you may well be reducing your risk of complications if you can reduce weight. So, partnership. Yeah. We're in this together. That's what it's about. Not a fight. It's not, oh, please do my surgery. Oh, no, you want me to methotrexate. I'm not doing your surgery. Oh, please. It's not a fight. We both want the best result, So, we'll get there together. Yeah. Louise says, thank you so much. There we go. Thank you, Louise, for asking the question. We've done the space between the cleavage. Pretty sure I remember doing that question. Yeah, enhance it. Yeah, sternum, definitely remember it. Yeah, it's all coming back to me. I'm looking at getting a piercing hole closed on my upper top lip. Upper top lip. Not the lower top lip. It's the upper top lip. And I wanted to contact you to see if this is something you may be able to offer. There's more. I have a hide thing. Here we go. It's a tiny hole on my upper lip, and it's been about 15 years since I last had anything in it. but I'm very self-conscious now about it. It's interesting. My cousin's daughter has got a piercing in her nose that she said, oh, I don't know, the hole, don't want the hole anymore. To be honest, the nose is probably more difficult than the top lip, but it's difficult. It's not as easy as you think, because you have to cut out. I mean, the hole will obviously be from outside to inside, so there'll be a epithelial. It'll be like a skin-lined hole from the outside to the inside. So you'd have to core out that hole and then close it, and it would leave you with a scar or a mark. I mean, scars do fade. I mean, the word scar is quite emotive, really. I think people get a bit. They sort of think, oh, crikey, I don't want a scar face, oh, God, terrible, but, it will leave you the mark, and the mark will be slightly, not much, but slightly longer than the hole, the piercing hole. So again, it's about balance, and it'll be, the other thing will be red and obvious to start off with, and then it fades, takes months and months to fade. And it's about balancing that against the, the risks against the benefits. Depends on how much it bothers you. But I've got to be honest, I'm always a bit worried about these piercing hole things, and a bit negative about it, to be quite honest, because I understand why people don't like them, but you got to be happy with the scar instead, and the scar will be like a little line. So anything can be done. Well, maybe not anything, but these sorts of things can be done. But should it be done? $1 million question. So yeah. So Gastric Fantastic Sealy, I can help with weight loss. So Gastric Fantastic can help with weight loss. Well, the BMI stuff. Yeah, there you go. So Gastric Fantastic Sealy can help with weight loss if your BMI is high. Good to know. I have scoliosis. This is oh God, what's happened? Sorry, we've got questions. We've got comments on Facebook. Thank you. Good to know. It's still a possibility. That's good, Sarah. Yeah, right. The H is silent the way. So just pronounce Payne Old Townsend. Yeah. So it is pronounced. It is spelled correctly then. So I apologise. It's spelled correctly. It is spelled Townshend, but pronounced Townsend. So that's not normally how Townsend's spelt, though, is it? That's an abnormal spelling of Townsend, I think. Is it? Pete Townsend. Is he spelt like that? It's a bit like Mannering, isn't it? Mainwaring is Mannering. But anyway, you'd know. I mean, I'm not. Don't ask me. I'm Staiano, for God's sake. So, yes, Townsend. Okay, good. Sorted that out. Whew. Didn't want to leave that open. Right. I have scoliosis. Can I have breast surgery? If yes, do I need to notify my neurologist? Neurologist for scoliosis. Okay. Have you got neurological symptoms then? Okay. Anyway. So scoliosis is a curvature of the spine. And when the spine is curved, the rib cage can be tilted. And when the rib cage is tilted, there can be breast asymmetry because of the tilt of the rib cage. One breast projects more than the other breast, and so the bottom line is, certainly if you're going to have your scoliosis addressed, you should have your scoliosis addressed first, because surgically, that is, or braces or whatever. You should have that done first before having breast surgery, because we'll have to compensate for the tilt in your. We may have to compensate for the tilt in your rib cage. It depends on how much of a tilt you've got. You might not have a significant tilt, but and therefore a sort of an apparent asymmetry. So you might have to use different sized implants. So there are all sorts of issues you can get with people with scoliosis. And if that's the case, if you have got asymmetry and a tilt to your chest wall, then that will be best getting fixed first before having breast surgery. Now, if you don't want to have scoliosis surgery and you're happy with your with that side of things, and you're just under sort of investigation, just watching, observation. Is that the word? Anyway, yeah, whatever, observation with the with your specialists, then you could consider having breast surgery. It is always best to notify your neurologist or the doctors looking after your scoliosis, and we would also notify them as well and write to them to say, look, is there anything that needs to be done before considering surgery? But there is no reason why you couldn't have breast surgery, I wouldn't have thought. The only thing is, and again, about careful patient selection and careful counselling with patients in the consultation. If there is a tilt, particularly if your nipples aren't pointing straight, if they've got a bit of a tilt to your rib cage, breast implants can accentuate that. So if you've got nipples pointing in different directions or pointing one way or the other way, implants can accentuate that. You can imagine, like a boat that's gone a bit off course, then it carries on going off course. It sort of gets more off course. That good analogy, the further it goes, gets, So it's like that. It's like a boat that's gone off course. The implants can accentuate a discrepancy in an angular direction if there is a tilt in the rib cage. So that's something, again, we'd have to look at, and just not a lot we can do about it short of fixing the tilt in the rib cage, which goes back to having your scoliosis fixed. But if you're not going to have that fixed, then we might have to accept it and just be aware of it preoperatively and just say, look, that's going to happen, that might look more, your nipples might look more asymmetrical if there isn't a tilt to the angle. But we could try and sort of balance out the volume. So I'm out of questions. If you've got any questions, you'll be more than welcome to ask them. If you haven't got any questions, that's fine. It's not a problem. There's no pressure. Don't feel bad. It's okay. 1944, so it's still early night. The night is young, but we can't really get out there. I was going to say get out there and just go to the chippy. That's about it, really. So I will check out in that case. If there's no more questions, I will check out because I've got an awful lot to do because I'm a busy man, obviously. And if you do have questions, if anything comes to you, then please feel free to just message me on Instagram or on Facebook or on YouTube, actually. We need to get some YouTube videos going on, don't we? Oh, hold on a minute. Off topic of conversation. Oh, look, Nicola. Oh, God. Oh, look at that. It's a teaser. It's a teaser. We don't know what's coming next. So do feel free to message me, and I will talk about it next week, or I'll message you back or whatever. But Nicola is teasing us with something off topic of conversation. What was the topic? Off topic meaning what? You mean off topic of plastic surgery, or off topic of whatever it was, like scoliosis and stuff? A bit worried if it's off topic of plastic surgery. Going to be in trouble. Oh, here we go. Here we go. It's in. The question's in. Panic over. I know everyone's different, but I'm wondering a lot about bruising post-augmentation. Yes, everyone is different. What are you wondering about? So some people talk about arnica, and people often ask me about arnica. Personally, I don't particularly recommend arnica because it's not normally significant. Now, the fact you're saying that, the fact you're asking the question leads me to suggest that maybe you have got bruising. But normally, bruising is not significant. Sometimes you get a bit here. Have you got a bit? Have you got a bit of bruising? Have you? I wouldn't worry too much about it. I mean, bruising is just sort of soft tissue damage, and it will get better in time. Here we go. Part 3 question. I feel like my bruising is going around in circles. Every time it heals, it then comes back in the same place. Got to be careful in terms of the bra. It seems worse each time. Is the bra fitting well? Is it? You want it to be supportive, not compression. A lot of people talk about compression garments and compression bras and things, but you don't want to take off the bra and think, oh, for goodness sake, I can breathe now. So you don't really want to be for the bra to be too compressive. Heals and then comes back in the same place. Yeah, sounds a bit. Yeah, but does the bra fit well? Is the bra tight? Is it supportive? Is it comfortable? Is it like, oh, that's a nice bit of support sort of thing? Right, yeah, day and night, that's good. Day and night is good for the bra, but you don't want it to be too tight, basically. Um, and is the bruising related to the bra? Is it like in the area of the bra strap, or is it elsewhere? Is it I mean, here's the thing I'm thinking: is it associated with swelling? Because that might be an issue. If it is associated with swelling, I probably want to see you. If it's not associated with swelling, now bruising often looks worse before it looks better. You know, it goes into that awful sort of purpley, yellowy, purple color. So that's not uncommon for bruising to take that sort of natural history. You probably know that, but it's a bit worried that it's coming. Oh, here we go. It's not tight. It doesn't leave any marks. It feels supportive. So the bra's okay. So that's okay. It's not a bra issue. It's in between cleavage and towards my scars. Yeah, so you sometimes get it in there just because it's a bit tight in that space between the cleavage and towards my scars. Yeah, and that leads me to think, did I do stuff? Sometimes I'll do stuff to the inframammary fold, you know, that area. Sometimes if the fold's not level, you have to do stuff to the fold, to that area, so you can get a bit of bruising in that area. Bruising in itself is not a worrying sign, and treatment is around symptomatic relief. So if you've got symptoms, then you're looking at helping those symptoms. And as I say, arnica, people talk about arnica, which can come as a tablet or a cream, can help. But bruising without sort of significant swelling, and there might be a bit of swelling, certainly there, I wouldn't worry too much about it. And maybe I need, if I do start getting people with a lot of bruising, I need to start thinking about, talking about arnica pre-op, because people do, starting it immediately post-op, because people do talk about it, and I do not say don't take it, but I don't tell people who don't ask about it to take it. So I was going to ask, okay, yeah, it'd be interesting to know. I mean, it's good to take it. It's interesting to know if it helps. I'm not sure about the evidence about it. Is there evidence with arnica? I think there might be. I'm not sure. But as I say, it is difficult, and it's always difficult when you get someone who gets bruising, because every now and then you get someone who gets quite a lot of bruising, especially with tummy tucks, especially with liposuction and stuff like that. You get someone with an awful lot of bruising, and there's me saying, oh, I don't really get much bruising, and don't really tell people to use arnica. And this person's sitting there thinking, hold on a minute, look at the state of me, I'm like, well, having said I don't get much, sometimes people do get some. I'm not saying I get zero bruising, and you've just demonstrated that. But it's not normally a big problem. So I don't normally talk about arnica, but maybe I should. Thanks for bringing it up. Keep in touch. Drop us emails. Send us photos. Send it to Vicky. Keep us posted. We all want to make sure it's all okay. But as I say, in itself, it's not a disastrous thing. Bruising, it's just a bit of a nuisance, and normally it always settles, but it can take a few weeks. Enhanced masturbacy. I'm 4 months post-op reduction lift. I still have no sensation in my nipples. Will it come back? It's often the case that you have alteration in sensation in your nipples following a reduction, and it's unpredictable whether it'll come back or not, because you have to isolate the nipple and move the nipple as part of the surgery, and you can't see the nerves. So you don't know whether you kept enough nerves in there or not when you do the surgery. But it's not unusual for it to still have altered sensation or / no sensation 4 months post-op. That is not unusual. It's normally about 9 to 12 months for it to come back, if it's going to come back. So it does take a while for it to come back. So I wouldn't make any long-term decisions until about a year. And even then, there's not a huge amount we can do about it to bring it back. And normally what happens is it feels really weird to start with, and then either it comes a bit back to life a bit, and or you get used to it a bit. So the symptoms get less. So it's not quite as bad as it is early on. And so it's not normally a big problem for people. And the bigger the reduction, the more of a prospect of alteration in nipple sensation. that is the main determinant, the size reduction, as to the alteration in nipple sensation. So Nicola, let us know how you're getting on. Email Vicky, give us photos, keep in touch. We want to know how you're doing. Make sure everything's okay. By all means, go for arnica, can't go to the shops now, can you? Have to get it off the old internet. But we want to know about that. I'll try and remember to mention this to Vicky to give you a call tomorrow. And peace out. Any other off-topic conversations? That wasn't off-topic. That was actually on topic. That was fine. Will do. Thank you. Good. Anything on or off topic? Actually, mainly on topic. Topic being plastic surgery, not off topic. On top. Anything on top. I shouldn't really move, should I? Because that's my audio device is not being. Anyway, on that note, I'm going to check myself out of here. Go and put my feet up, and I suggest you do likewise. Thanks for dropping by, and I will see you same time, same place next Tuesday night, God willing.